Welcome everybody. As has already been mentioned, my name's Emma Wadey. I'm a mental health nurse, still practicing clinically, but I also work in NHS England. I'm the lead mental health nurse for England in that team, and have a little bit of a dual role in that I also work and lead some big programs of work actually linked to the mental health of specifically the nursing workforce, but actually much more widely now in terms of the mental health of the wider healthcare workforce, including suicide prevention. The reason that I wanted to be involved in this conversation, and this is going to be a conversation between myself and Hannah, who I'll hand over in a second to introduce herself, is that since COVID, there has been a far greater awareness, and quite rightly so, around the importance of maintaining our mental health in order to best meet the needs of patients, their families and our communities, but also a recognition that many nurses do experience mental ill health and perhaps don't always feel able to seek the help when they need it in as timely way as they need it. I'm also aware that many colleagues experience quite a lot of fear and anxiety about supporting colleagues, raising concerns about their colleagues in terms of their mental health and well-being, and perhaps even treating colleagues when they step forward for mental health support and interventions. And so we really wanted to spend some time this morning exploring some of those things in order to think collectively together about what good looks like, how it can really enhance nursing practice when we reach out and seek help and support ourselves, what that means for our colleagues. And the reason that this is so important is two things really. One is we may be nurses first, we may be healthcare workers first, but actually we're all human, which means as humans we are susceptible to experiencing mental ill health. Many of us on this call may have already or be experiencing mental ill health. We know that 1 in 3 of the population will do at any one time. So given the significant number of nurses, although of course not as many as we would like, it is inevitable that some of us will at some point experience mental ill health. And it's really important that when that happens, people are able to access the support, the treatment, the interventions that they need. Secondly, those of you may already know, some of you may have already heard me speak before. It is vitally important also because nurses, particularly female nurses, have a suicide rate which is 24% higher than the female population. That percentage is for England and Wales, but actually nurse suicide is actually a global issue. And that's not to say, of course, that becoming a nurse instantly makes you suicidal because the work is so terrible. That's not the case at all. But there's something to consider for us in that, is there something preventing us seeking support when we need it? Are there things that we could do differently within our workplaces, which mean that we're able to maintain our mental well-being better? And it's just starting those conversations really to ensure that we're doing everything that we possibly can to look after ourselves, to look after our colleagues, and ultimately to enable us to look after our patients, which of course is why we come here today. I'm going to hand over to Hannah, but just before I do that, I'm going to keep an eye on the chat. And we really, really want this to be as interactive as it ever can be doing a webinar. And so we really do want to see your comments, your questions, and I'm going to do my best to interweave them into the conversation as we go through, although of course there will be some opportunity at the end, hopefully for some questions as well. So please do interact with us in any way possible from that virtual perspective. But I'm really, really delighted now to hand over to Hannah, who's joining us this afternoon for this conversation. So welcome, Hannah.
Hello, so hi everybody. It's really nice and it's really lovely for Doctors in Distress to kind of include this, because I think when I think about this, I think of, I suppose, what Emma, to reiterate what Emma says, when I introduce myself, I like now to say that I'm human, because I think that I hold many hats and I'm not always going to hold those hats. I'm not always going to have those roles, but I will always be Hannah, who feels just like everyone else. And I was saying to you, wasn't I, Emma, that actually it seems like the language that we share across the globe is the language of emotions and feelings. We all know what it is to feel angry. We all know what it is to feel frustrated and fearful and joyful and happy. And actually, it's the emotion that we have that we share. After that was said, I could hear birds in the background. That's quite nice. As I'm wearing birds as well. So the roles that I do inhabit at the moment, I am a service user of mental health services. I have a diagnosis of serious mental illness. I'm also a palliative care nurse, and I work at a hospice in London. And then I'm also a lecturer at Roehampton University, where I lecture with both my hats of lived experience and nursing.
Hannah, you've gone on mute.
I don't know how that happened. So yeah, and so I wanted, since I was sectioned under the Mental Health Act in 2007 with my nursing uniform in my bag. It was a very, very shocking experience. And that moment that I was first sectioned, I thought I will never be a nurse again. That wasn't the case. It took 12 long, hard years, but I returned to nursing in 2020. And then since that point, I've really wanted us to have this discussion. And though I find it heartbreaking to sort of hear that nurses are saying that they're struggling and doctors are saying they're struggling, I also feel hopeful that this conversation's being had, because I think back in 2007, it wasn't. As a nurse who went into the mental health system and was given a mental health diagnosis, I felt very alone. I felt very alone in when I decided to start speaking about it. And I'm glad that we're having this conversation. I think it's such an important conversation. So in that way, I feel hopeful that this is what we're talking about, because I think once we talk about it, we can then really think about how do we help? How do we help the situation? How do we look after each other, ourselves, and then our patients? So yeah, I'm really excited that we're having it.
And Hannah, you mentioned there about your experience back in 2007. And I know that when we've had discussions before, you've described what it felt like in that moment and the care that you received in those early days, well, those early hours actually from the nursing staff around you. And I wonder if you could just share a little bit more about that, how that felt.
Yeah, I think it was really hard. I think it was really hard for nursing staff because you've got a nurse who's come in and has been sectioned. And I think I got different responses. I got nurses who were just like, this is really scary. I don't know if I can look at this, because I think it made them fearful themselves. And then I had nurses that were just like, my goodness, we really need to help this person. They're one of ours. We really need to, how can we help? And so I think there was those two sides. And I think when I look back now, it was the nurses with a bit more experience who could sit in the painfulness of having to look after a nurse that had come in. And I think it was nurses maybe with less experience who were feeling scared, actually how this it felt too much close to home. And it makes me think now about how do we ensure those reflections of what it is to be human, and the fact that mental health doesn't discriminate. It can be anyone, which means it also can be healthcare staff. And actually what we're hearing is actually we can be more susceptible to it. And it does make you wonder why, because the other thing is that it can then go into that assumption that it's the nursing that's caused it. And the amount of people that have asked me, was it the nursing that caused your mental health? And I remember having a discussion with my psychiatrist of like, was it the nursing? Because you're questioning yourself because you don't really know yourself. Because when I was sectioned, I didn't know why I was having suicidal thoughts. I didn't have the language to explain what was happening to me. I was confused. I had no explanation. And so I was questioning, why is it happening? Was it the nursing? What's going on? Because you don't know. And I think that's what's scary about it. you don't know what's happening. But when I did discuss it with my psychiatrist many years later, I remember him saying to me, it wouldn't have mattered if you had stayed being an embroiderer, if you'd been an airline pilot, you probably would have had a breakdown, because sadly for me, it came from my childhood. And I think the experiences of nursing where I was seeing kind of people die, actually what it was doing was it was bringing up those emotions and feelings of deaths that had happened in my childhood that had been suppressed. And I didn't know that that was what was going to happen, because that had been suppressed. And then when all of that started to raise up to the surface, I had to step out of nursing to understand what all of that was, understand my pain, my trauma, which then meant that in understanding that, I could return to nursing, and be a much more effective nurse. And I was very privileged in the sense that the hospital, one of the hospitals that I went to, which is a therapeutic community called the Castle Hospital, it was such a privilege because actually the mental health nurses there not only saved my life, because I was somebody who did make very serious attempts on my life, and was nearly one of those statistics of suicide, particularly in 2009, where I went into respiratory arrest. Not only did they save my life, but actually they taught me how to sit with the powerlessness sometimes that we have to sit with as nurses, and that I could sit with that, and I could sit with some of these difficult emotions, and I could sit with that fear of what we sometimes sit with as nurses. And I'm so thankful to mental health nurses for teaching me that. I really am.
And I promise I didn't ask Hannah to say that as a mental health nurse. So we've had some comments already, Hannah, that is probably quite timely. And one of them was just about that, really, that we do bring stuff with us into our nursing role. It's very common. I saw some statistics, I think from what was Health Education England back in the summer, that all fields of nursing practice, actually about a third were disclosing that they had a mental, not necessarily a current mental ill health, but had experienced psychological ill health, mental ill health, as well as physiological ill health. So it is quite common, and it's common for people to say that they came into nursing because perhaps of their experience of nursing or caring for others. And yet perhaps we don't pay enough attention to that actually when we come into practice, about how we might then one, share those experiences and what's appropriate and what's not around professional boundaries, but also how different scenarios may impact us and what additional support we might need during that time. And I wonder, for you, thinking now about that, was there anything that should have been in place prior to 2007 that may have meant that you wouldn't have then needed that admit? I know it's probably quite hard to say, but I was just wondering about that. You know, could there have been something different at that time?
I think it's really difficult actually, because when I look back, I actually ended up in a really supportive team when I first went into nursing. And the manager actually that I had at that time, she actually supported me return to nursing. So it just shows how supportive the manager I had at that time. And they couldn't see what was happening. She said, we just didn't see it in you at all, Hannah. And I think that there's the difficulty with me, and I think it's really good that people are beginning to say, and I think that's really important. And I think we need a culture that says it's okay, because then those things can be put in place. Because actually the difficulty with me, which wasn't connected to nursing, was more connected to my childhood. And I think we need to remember that was the culture that I came from. And the culture I came from was mental health wasn't really a thing. It wasn't something that you spoke about. I came from quite a religious background that said that suicide was a sin. So all of my background, and I was also taught that I was very privileged, that I'd been given a very privileged life. I'd been taught about God, and I had a duty to kind of be a responsible member of society, really, because I'd been given so much. So what was going on for me at that time was not somebody who was going to seek help. I don't think it would have mattered if anybody had even recognised that I may need help. Would I have seeked it? And I don't think that I was able to sort of say. And so for me, sadly, it got to a point where I was sectioned, because in the end, help just had to be kind of forced on me when it was clear that I was self-harming without anybody knowing. And I think that that's a very important thing for us to recognise, the fact that we all come from different places. And that actually, how do we, as healthcare professionals in a healthcare service, when we're looking after each other, how do we say, here, it's okay? This is okay to do this. And actually to recognise there will be people that will be coming in as healthcare professionals who will have come from a background where it's not okay. And I think that's where it makes it quite complex for somebody like me. But I think it's good that that's being asked, because otherwise we can see that all the responsibility lies in the healthcare system. And I think it is, we need to make a culture where it's easier for people to say. And I think that's a good thing. But I think it's also important for us to realise that we also come from our individual lives that also can stop us. And how there's still that, we kind of need to be a shining light to say this is an okay thing for us to talk about. I hope that's made some sort of sense. I don't know how helpful that was, but my experience.
I think it's a really helpful reminder, because actually there isn't going to be a one size fits all. There isn't one solution. There isn't an approach or a way of doing things that's going to meet the needs of every single person or every single eventuality. One of the things that has come up, and I know it's something that we've talked a lot about, is of course about stigma, whether that's stigma from others or whether it's stigma that we place on ourselves, and how difficult it can be. I mean, someone's already commented, for instance, how brave you are. Would we be saying someone's brave if they were describing their cancer story or how they've lived with diabetes for 20 years? It's interesting the language we use. But I wonder if we could have a little bit of a discussion around that stigma, because certainly that, and it links with fear, and the fear someone's mentioned around the stigma attached and the fear of dismissal. And you spoke right at the beginning that it took you 12 years to come back into nursing. So I wonder if you could share some of your experience of what that took, what that looked like, and how that stigma and fear perhaps perpetuated and lengthened that journey back into nursing.
Yeah, I mean, I think we know there is stigma out there. I think that there's your own self stigma, isn't there? And I think that can happen for us, but as nurses, and I think healthcare professionals, because we see ourselves as the carer, it's like, that's my role, that's my identity. I care for people. And then it's a horrible thing when I got sectioned and suddenly that felt like it was over and nobody would then share anything with me. And just feeling so useless, like I didn't belong anywhere. And I remember there being a moment where I just thought, so randomly, I will tell you this story because I do tell it to students, that before I was a nurse, I was actually an embroiderer. I trained at the Royal School of Needlework, so I was a professional embroiderer before I went into nursing. And I think probably I was having mental health difficulties at that point, but I thought I just need to make a change in my life. My hobby's become my job, hasn't worked, let's go into nursing. Now I look back, I think, actually, I was really struggling and I thought I just needed to change kind of my life. But because of that wonderful thing of being an embroiderer, I did end up working actually on the now Princess of Wales wedding dress, because I was asked to go back and work on it. And I was very unwell at the time. And I went back into hospital and I told a nurse, and she assumed that I was deluded. And I remember at that point, and fair enough to the ward manager, she went to the ward manager, said, I'm really worried that Hannah's deluded. And he did turn around and said, if Hannah told you that, that will be the truth. But I remember at that moment thinking, I'm no longer an embroiderer. I'm no longer seen as a nurse. I am purely a mental health diagnosis, and not a particularly one that has many nice words associated with it. So if any of you are healthcare professionals here, it's emotionally unstable personality disorder. And it has huge amounts of horrible words connected to it, like manipulative and attention seeking, and suddenly you think, who am I? You're struggling with coming to terms with why you've got suicidal thoughts, why you've begun to self-harm. to understand what's happening for you, to also then having this diagnosis and thinking, well, what does that mean? Who am I? And not feeling like you can get a sense anymore of who you are. And so it was a really hard kind of journey to go on. But it was amazing when I ended up at the Castle Hospital, because I walked through their door and they were just like, "You're Hannah, and you've ended up with us, and we just want to understand what's happened to you." And that feeling that I could then just feel like I was me with everything that I brought to the table. And it was that feeling of just being able to be, I spent a whole lifetime of hiding certain parts of myself. And at that point, I was just allowed to be who I was, everything that meant that I was. And I think it's how do we allow that for people to be their authentic selves and it to be okay. And that journey then back into nursing was quite interesting in the sense that there were many people that were supporting me, and they were like, we really believe in you. You should be a nurse. Because I was the one that was saying, I don't think they'll ever let me be a nurse again. I don't know if I should ever be a nurse again. And there were many, many people that were really encouraging me and saying, no, we think you should, because actually you've got something really important for the nursing profession. So there's this huge encouragement. And then there was also this huge fear as well. And when I went to see occupational health, because of that fear, though I had letters from my psychiatrist, my GP, the Castle Hospital, they actually insisted that I had to see a psychiatrist who had worked for the General Medical Council on fitness to practice cases to say that it was all right for me to do my return to nursing. And I remember thinking at the time, would they have asked me that if I had had a physical healthcare illness? Would I have had to see a separate specialist to say it's okay for you to go back into nursing? And that was quite hard because I did feel like I was being treated differently. So the stigma, I don't know whether that's really explained it, but the stigma, there was the self-stigma, there was kind of stigma there, but actually there was also people who were really encouraging as well. So I think the thing is, you never know. You never know how somebody's going to react. And that's the thing that's very difficult then to be open. So I know that when I returned to nursing, I was at the time doing this embroidery class with on a mental health unit. And we were actually working on the Grenfell quilt, and it was a lovely little group. It was such, amazing. We just had such amazing conversations, and we'd just sit there, stitch and talk. It was brilliant. And when I started my return to nursing, that little group was so encouraging of me. And the place where I went to do it, my placement, I didn't know how people might react to me, knowing that I'd had such a serious mental illness. So I told them that I did this little sewing group in the local mental health unit, and depending on their reaction, depended on whether I disclosed. So I think it's that. It's just, you just don't quite know what reaction you might get.
And it sounds, Hannah, from what you're saying, that there are two things there. One was that individual reaction and then you kind of tempered what you might tell them in that moment, but also some of the systemic stigma that was in place, around the systems around occupational health, and the hoops really that you were made to jump through that may not have been the same had you been returning to practice for perhaps a physical health illness, for instance, or perhaps just a period away from nursing in a different career, and a career break. And I know obviously it's a little while ago now, but just reflecting on that systemic stigma and thinking, do you think things have changed?
I think the fact that we're having this conversation, I think, shows that things are changing. Because I go back to 2007, and if there'd been something like this, I probably might have tuned in. If I don't remember there being any particular conversations around healthcare professionals and mental health. It was beginning to change because we had the time to change. I don't remember, that's still out there actually, but the time to change kind of campaigns had come through, and there were things that were changing inside the mental health system that was saying about peer support workers and how important peer support workers were in terms of giving you that hope that there was things beyond kind of, you know, mental illness, and you could find a way through it and you could find a way to manage it. So some of this is building on some of those things, but I don't ever remember there really being a time, I would say it's come since the pandemic, for me personally, from what I can see, that there's been this real beginning conversation that says, actually, we're all human. And this also happens for healthcare professionals as well. And we really need to think about that. And I think what shocked me more is your statistic, actually, Emma, that actually it's actually larger in nursing than it is in the rest of the population. And even somebody like me, who was a nurse who had mental health difficulties, even I didn't realize that. And I think that's the part that makes me, you know, breaks my heart a bit, but also so thankful that we're having these conversations.
Yeah, I mean, even so I've worked in suicide prevention probably the whole of my 20 plus years. And, you know, I'm ashamed to say that I wasn't aware of the suicide statistics around female nurses. We have focused very much primarily on men, and rightly so in many ways because of the large numbers. But so I think there's something about this being a female profession issue, that there has been this silence, but I think that's also been wrapped around in stigma, fear. Even the conversations now that I've had colleagues who haven't wanted us to talk about nurses and mental ill health. One, because they fear it will put others coming into the profession, because there will be this link made that, oh my goodness, nursing is so stressful, it's so awful, that actually you're going to experience post-traumatic stress disorder and you're never going to be able to work again. But also just acknowledging that shift over time. I'm old enough to remember the Beverley Allett inquiry and the recommendations. And that also stoked a lot of fear around nurses and mental health, and what the behaviours of nurses who experience mental health might be, and a real push not to screen out nurses. And I wonder if that prevails. So for those of you not old enough to remember the Beverley Allett case, this was a nurse who was convicted of killing babies in the early 90s. She had a diagnosis of borderline personality disorder, and the recommendations actually required that nurses who were, or aspirant nurses applying to do nurse training, should be screened by their GP for mental ill health. And I was one of those aspirant nurses that had the screening. Somehow I must have scraped through, Hannah, or was under the net somehow. But also this idea that this linkage really, that by having a mental health condition made you dangerous to patients. And I guess there is still that prevailing, not necessarily linked to nursing per se, but the general public, there is still that fear that having a mental illness makes you dangerous. And I wonder if that drives some of the systemic fear around regulation and the jumping through hoops, but also the fear that keeps it silent. It keeps nurses silent about sharing, and it keeps perhaps others silent about raising the profile and doing something about it, that kind of, that fear really. So I don't know what your thoughts are.
I think that, you know, it is hard, and I think that makes it really hard to say that you've got a mental health diagnosis. And I think that it's actually making me think. I've actually got this just in front of me, and I think I will share it, which was actually a study that was done only in 2021. It was a rapid scoping review. So actually it was looking at quite a number of studies that were done. And I'm just thinking, just 17, in fact, that they looked in terms of healthcare professionals disclosing about their mental health conditions. And it's called Healthcare Professionals Disclosure of Mental Illness in the Workplace, a Rapid Scoping Review. And 8 of the articles actually from the UK. And I just wanted to read their conclusion, because I think there's some really important parts in the conclusion which I think are really important. So it says, the review adds the body of research about the mental health of healthcare professionals. Disclosure of mental health difficulties in the workplace is a complex process for healthcare professionals that involves weighing the risks and benefits of disclosure in employing a decision-making process to discern the best way to disclose, resulting in largely negative consequences. Disclosure is not always within the control of the healthcare professional, as there are several ways in which their mental health difficulties can be made known to their workplace accidentally or without their consent. Healthcare workplaces should strive to create safer disclosure environments for disclosure, recognising the strengths and values healthcare professionals with mental health difficulties can bring to their professional roles. And I think it's the last sentence that's really important to me, that actually I needed a period of time where I couldn't look after patients. The way that I often say it is, there's that thing from the 1960s where we talk about wounded healers. So we've had this conversation for quite a while, that actually lots of healthcare professionals can be wounded healers. And that's actually a real strength. But actually I had a period of time when I was sectioned under the Mental Health Act where I was just wounded. And I needed to understand what they were, and I needed to figure it out, and I needed a way, a safe place to and an understanding. And I think the stigma then did make it worse. I think for a long time that then my own self-stigma meant that actually I think I was not helped. It took longer, I think, because of that. My sort of position within inside the mental health system took longer. But actually in coming through it, the skills that I learned, and I think it's that thing that actually, though there's not a cure, somebody can't just, give you something and take it away, actually I am able to manage my mental health. And actually I learned some real brilliant ways to manage it. And a lot of what my mental illness was kind of a grief process. I had to grieve what had happened in my childhood and had happened in my life that I couldn't go back and I couldn't change. And actually being helped with that, to help what's understood with me, to help to understand myself, to learn how to manage my emotions, actually now gives me many strengths to understand sometimes some of the emotions that patients are trying to explain to me, some of the ways that I've managed it, that I can try and so actually the growth and the learning through that illness has meant that actually exactly what this article is saying, that actually there are many strengths that people then bring. And actually, where do we then value that? And where do we say, do you know what? Mental health services really do help people. It really does work. My therapy really did work. And I think it was that part that I found the most upsetting when I went to occupational health. And I do actually remember saying to an occupational health doctor, I said, this isn't just a disservice to me. This is actually a disservice to the mental health system, because we need to see that this works just in the same way as if somebody had broken their leg and the surgeon had done a really good job, they can then go back to work. The mental health system actually for me did a really good job in the end. But I think that's also another part, and another part of this is actually, many of you may realize that, the mental health system has been a poor cousin to the physical healthcare system for a long time. And actually, does there need to be, the support that we put in place that actually says, you know what, this is of real value. This really helps people. People really need this. And actually, how do we really sort of say that there does need more funding in this area? This is what, we do need this. People do need, and actually where that can then lead. That kind of went a bit off topic there, I think, Emma.
I think people are just enjoying hearing what you're saying. So when you've got a time at the end, I hope you get a chance to read all the positive messages and how just inspiring it is to hear you. I think just picking up on a couple of points, and I will try and weave in everyone's questions and comments so that this flows, just to reassure people. So please do keep them coming. But I think from what I'm hearing as well is that balance of hope, and making sure that there's balance in the stories that we tell and what we share around, as awful as things can become and as underfunded mental health services are, and not underestimating or trying to minimize the fact that some people don't always get the best care in the timely way. But when it does work, it is fantastic. And it can work, and it can absolutely work for everybody, as well as nurses, and enable them to come back to work and be. I know you often talk about that you think you've been a better nurse. And I wonder if you just want to share a little bit about what you mean by that and how you've used your experiences to really shape your nursing practice.
So yeah, so I'm actually going to read a section that I wrote, just because I just don't think that I could say it again in how well I wrote it. So I actually was asked really kindly to input into a book which was called Working with Serious Mental Illness. And there's a little paragraph, I suppose, that is sort of like my kind of letter to nurses, really, about what I learned, I suppose. So I hope you're all right if I read that as well. So when I reflect on when I was first a nurse, I can see that I often wanted to do something to take away patient suffering. And when I couldn't, I would have an overwhelming feelings of failure and powerlessness. But as a nurse, I had underestimated the power of solely acknowledging another's pain. As someone who went from a nurse to a long-term mental health patient, I have learned that acknowledging another's pain is an act of pure compassion, because in that moment of powerlessness, you are standing beside somebody in their suffering, knowing that you can't take their suffering away, but you are acknowledging it. And I think that was probably the biggest thing that I learned, that actually we underestimate completely as nurses what it is just to sit and listen, acknowledge and validate what somebody's saying to us. It was one of the most powerful things the mental health nurses gave me. They didn't try and make it better. They didn't try and say, oh, this solution, that solution. What they first did was they listened. They really listened. They acknowledged that it was suffering for me because I needed that. And they validated it. They validated my feelings. And once that happened, the extraordinary thing was that I then began to be able to find some of the solutions that were going to help me. And if I could give that to every nurse and say, do you know what? You don't need to feel like you need to find a solution. Sometimes there isn't. But acknowledging is massive. It's just huge when somebody feels that their feelings around something is validated and acknowledged. It's just such a gift when somebody does that for you. And I think this is some of what we're trying to do here, actually. We're trying to acknowledge that actually, for doctors, for nurses, for actually many healthcare professionals, OTs, social workers, peer support workers, we are all working in a field where we see huge suffering, but we also have our suffering. We're human too, just in the same way. And actually, that some of what our strength is, some of what's brought us into the service is because we have that sensitivity to that. But also that can be our Achilles heel. And how do we look after each other? Because actually our sensitivity to suffering is our very strength, but it also means that we can then not always look after ourselves. And we need to get that balance right for each other. We need to kind of look after each other. But actually, I think also we want to make it better. And how do we sit with knowing we can't always make it better? But what we give in really listening to people and invalidating what they're saying, that is of such high value. It's huge when we can sit in that space and sit with powerlessness, because that person is sitting in there alone. And when you come and step in and say, I'm hearing that, then that's so hopeful. It's really hard to say. I know that somebody said to me, somebody I really respect called Tim Copeland, and he said, is there a power in owning the powerlessness? I kind of think there is. For me, there was in owning that powerlessness. Somehow, hope came. It's really hard to explain. I don't know if I explained it very well, Emma.
You're doing a fantastic job, and as I say, we're getting lots of really positive comments. And I guess that's the thing, isn't it? Often as nurses, healthcare workers, we're always looking to problem solve, to find a solution, and there's lots of pressure from above sometimes to increase our productivity, to push things through quickly. And what I'm hearing from you is two clear things. One, that there is time, and giving people time and having time is really important and significant, not trying to rush it through. And actually the power of sitting with someone, carrying hope when perhaps they don't feel there is any hope, and kind of just sitting beside rather than doing to, and how important that is. I'm also minded that I remember in one of the trusts I worked in not so long ago, a physical health nurse colleague walked onto a ward and said, "Oh, there's not very much action on here." She said, "All I can see is people sitting around having cups of tea." She thought that was awful. I thought that was fantastic. But again, it just goes to show that different perspective of what good care looks like, or what productive care looks like, and how different that can be and what that can look like. And just reminding ourselves, it's not what it looks like, it's how it feels to the person.
Yeah.
What you've said, it just really eloquently says it all, doesn't it?
And I think it's that thing that I realized that as a patient, the small things were the big things, that actually, but I think try how to do that sometimes can be really hard when there is all that pressure. And it's interesting when I work at the hospice, and I know that between like 1 in the morning and 6 and sort of like overnight is some of the most horrible periods. Your mind is, when I was unwell, that was my worst time, between 1 and 6. And that's why I have such a heart for mental health nurses, because I tell you what, is the mental health nurses that they're between 1 and 6 in the morning, to try and help you through that horrible period. And it's really stayed with me. And I know at the hospice, when we have patients who are distressed, that I will, there'll be times when I'm sitting in their room and I've got my hand kind of over their hand so they know that I'm there. And then my other hand is doing my notes. And then in my pocket is the phone for the community. And, and it's all the other things sometimes that we have to do. And yet, this thing that's not so measurable, that doesn't have a tick box exercise, is the most important thing. And how do we say that is, the value of that, and the importance of that, and how hard that I think that sometimes can feel for nurses and doctors to be able to do some of those small things, because that's the bit that isn't seen, but it's the thing that you remember as a patient. And it's how do we as a profession value that again, say this is so important.
And value it for ourselves, isn't it? Because I'm minded also that thinking about things like restorative clinical supervision, the amount of time that nurses say, I haven't got time to do that. So even in ourselves, we don't invest time in, or give us a similar amount of importance to looking after ourselves, taking time away, having time for reflection, having that cup of tea even, and really saying to our colleagues and sharing, how are you today? What did you do yesterday? And so it's almost no surprise that perhaps if we don't value it for ourselves, then it's not valued as an intervention in itself for the people that we're trying to support.
Yeah, I hadn't thought about it in that way. That's quite an interesting way to think about it.
I think we've got some examples and comments that I just want to raise now, if that's okay, Hannah. So a couple of people have asked specifically around training, and I know that you yourself are now involved in training nurses. And I wonder if there's some key things that you have incorporated into that training that you think has had the most impact around this particular topic of seeking help yourself when you need it, but also knowing how to reach out to others when they are seeking your help.
I think because I'm in early days of that, you suddenly realise you come into another system that you're like, oh, needs a bit of change of, how do we have these conversations, with student nurses and you know, in sort of like training. And I think it kind of goes back to what you were saying in terms of that restorative practice and reflection. And I think, are we teaching people to actually reflect in a way that's really actually restorative? And I think we've often got so many things we want to teach. We're often not doing that. We're not teaching how to do that really well, and how we kind of look after each other. I don't see that enough. That's what I would like to bring in more about how. And I know that I did one day, 2 days actually, at university, where we did 2 restorative days. And we went around and we did it. We talked about time. So what was time like for patients? What was time like for staff? And there were some amazing things that came out that the students shared, that the only time that they get just for a moment in the shift is when they're in the toilet. And it was just this real honesty. And then we actually talked about sounds, and we actually went round in nature, kind of recording sounds and what sounds were there. And we did a bit of mindfulness around sound. And then we talked about what sounds were like on the ward, what they were like for staff, what they were like for patients. And actually, we joke actually at the hospice that the phone we have overnight, that ring literally causes us to go like, oh my goodness, the phone. Like, what's it going to be? And we often sort of say that, when we get to the point where we're in a hospice and we hear that sound, that we'd probably need quite a bit of sedative. So this thing of actually how things affect us, and what those 2 days for those students of that real thinking about it, processing it, kind of having some techniques taught to them in mindfulness was really powerful. But that's quite unusual. It was like a sort of project that was done in the university that was a bit of a pilot kind of thing. And I think there is more that we can do in this work of how we do restore ourselves, how we build up our batteries. Because if I know anything as a patient, I could tell you which wards I worked on where there was really good reflective practice and restorative care, to the wards there wasn't. I knew, because I received better care, as we know in the research, but I absolutely know myself which wards had that. And that didn't mean that there weren't really good staff in the other ones, but because they didn't have that and they weren't working so well together, it absolutely affected my care. And I sometimes feel like it shouldn't be this way round, because I'm trying to persuade people to do really good, like, restorative practice and reflective practice, because it actually impacts patient care. But really, we should be doing it also for ourselves. But that seems really hard for nurses. So if you tell nurses that it helps patient care, you find they're more likely to do it, which is a bit of a oxymoron, really. But
No, I quite agree. It's something that we hear a lot. So certainly what we're talking about much more in our language, and some of our policy shifts has been about talking about opportunities for reflection actually being patient safety critical tasks, in the same way as we might do a level of observations or an intervention to prevent deterioration and improve quality of life, speed up discharge, etc. So we have started to change the language to really say, actually, looking after ourselves, looking after our colleagues is patient safety critical, and really shifting that language to start thinking in that way. But of course, you can change the language, but changing behaviours does take that little bit more time. But it's a work in progress, I would say. And I suppose the other thing I'm just thinking through what you were saying at the beginning as well is really thinking much more about what we bring as whole people, and what we bring from our experiences, from our childhood, our experiences in work, are actually strengths, not weaknesses to be held against us. And there's been some comments around that, and also how sometimes when people disclose that they have previously had mental ill health, or experiencing now, or that's taken as an excuse for them not being able to see 100 more patients. So rather than sorting out the issues systemically around the fact that we've got not enough staff, it becomes held in the person as not being, I hate the word resilient, or productive enough, and it being seen as a weakness. And so again, lots and lots of work to do to challenge some of that assumptions, and it needs to be more than one person doing it, doesn't it?
It does. And I think when I returned to nursing, I was very fortunate and I did think about it. But, the team at the hospice that I work with, I hate the word resilient, but people do seem to like it. And I always say I'm not very resilient, but as a team, we're resilient because my strengths add to that team. And then other people have other strengths that I don't have, and they add to that team. And there's this looking after each other and valuing each other. Um, and and I see that team also made up of our doctors as well, and our social workers, all the other people that make up the teams, and how we look after each other and how we value each other. And that's something that I, have been trying to kind of instill in the students, that all of us have a job for that. So what I've started to doing, and it has made me think actually doing this with Doctors in Distress, is we've got I know most of the numbers for all the nurses because
Oh, you've been flicked on mute again.
I did. So we've got like a WhatsApp group, and I know all the numbers. So at the end of a shift, because I've never done that shift on my own, I've always done it with this incredible group of people that have supported me through that shift, so that we did it together. I always say thank you. I thank them for just the fact that we did it together. But it really made me think, because I don't have the doctors' numbers generally. And actually, they've been part of that. And actually thanking them as well, and all the people. And, included in that, obviously, is our housekeeping staff as well, who, I do know their numbers. But actually, how do we thank each other? How do we say that? Because actually, we need validating. As much as our patients need validating, we need validating. And actually, how do we validate each other? Because often, as I look back as being a patient, I couldn't do that. Our patients do that for us sometimes, they do, because they do thank us. But actually, our patients are really unwell, and sometimes they can't. And sometimes they're going through really difficult things. How do we do each other? How do we give each other value? And that's really important, because I think when it does come to mental health difficulties and struggles, and we look at some of the research, it is about people feeling that they belong. It is about people feeling they have value. It is about really valuing what they're bringing. And I think that's what I'd like to change. How do we value each other? And I think that can come harder when we're in a system where we're constantly fighting fires. And I suppose that's the other thing I also think about, of being somebody that sits on both sides of the sort of fence, really, of both being somebody with lived experience and somebody who's a nurse. How do we also create systems together with patients that maybe are more effective? And I know that I was just going to tell you this little story that happened on a mental health ward, and the staff were short-staffed, and they knew that they weren't going to be able to give all the patients leave, because the patients if you're not mental health staff, are detained, and you get like the consultant will then say that you can go out on leave, but you often have to go out on leave with a member of staff. So they knew that all the patients then weren't going to be able to get leave. And so they actually had a community meeting, and the patients decided that day who would get leave. And together, they then meant that they together kind of dealt with this very difficult situation of the ward being short-staffed. And I think, and I always think that, how do we work actually to create services that are more preventable services, so we're not in this crisis services where we're constantly fighting fires, which is actually having an impact. And actually, how do we sort of look after each other? But I think the other thing I want to say, though, because I want to leave it on a hope, is that actually I had a really serious mental illness. I never thought I would be a nurse again. And I fought to be a nurse again, because it is such an incredible profession. It really is. And my fight to be a nurse again, I can tell you, was not easy. And I'm so glad that I am. I am so glad that I can give what I can give to the nursing profession, and that I'm able to do this for however much longer I'm able to do it, because it's such a privilege to be allowed into people's lives at most the hardest time of their life and be able to give something that is helpful to them. And if we know anything about the 5 ways of well-being, one of those is being able to give. And my patients every single day allow me to give to them, and that is a gift.
Thank you so much. And I don't think there's anything that I can say that could top that as a finishing line. Only to say, and I'm sure it'd be echoed by everyone on the call, we are so grateful that you came back into nursing, not just to share your story of mental health nursing, but because of the most fantastic care that you continue to give to your patients, and the support that you give to students as well, in terms of, yeah, bringing hope for them as well, actually. And I just wondered, for the last minute or so, if you just had any top tips, perhaps, or further words of wisdom for nurses, for healthcare workers more generally, that say this focus has been on nursing and nurses, but of course this can equally apply to other professions. So what would be your final words to nurses that might be suffering at the moment, that are fearful for reaching out, but also to those who might be worried about a colleague and just don't know quite what to say in order to support them?
I think that if I'll go for the second one first, that if you're worried about a colleague, I would say to listen. I'd say what I said, to listen, to really acknowledge what's happening for them and to validate it. And that actually, once you do that, you hopefully will be able to work with that colleague about what's the best way to then help them. So that's what I'd say for that. I think if anybody's struggling at the moment and you're in that really dark, hopeless place, it is really hard when you're in that. And the only thing that I can say is, as somebody who was in that really dark, hopeless place where I thought there was no way through, I did find hope. And it actually, sometimes other people are holding the hope for us. Let them hold the hope until you can take it back. And I believe that you can get through it, because I did, and I didn't think that I would. And I absolutely believe that you can as well.